All right. So I'm going to talk about tumor mutational burdens in histiocytic neoplasms in adults, Erdheim-Chester disease and beyond. It's from our group at Mayo Clinic, the Histiocytic Interest Group. I have no conflicts of interest to disclose. As you all know from the work done by folks in this group that vemurafenib is now FDA approved for BRAF V600 mutant ECD, but we still lack approved therapies for non-BRAF V600 mutant ECD, as well as other histiocytic neoplasms in adults. So most of these patients, overall, if you look globally, they end up getting empiric therapies, immunosuppressants, chemotherapies, and so forth. So a lot of the folks in this room, I am sure, are aware of immune checkpoint inhibitors. Nowadays, every cancer patient and non-cancer patient actually wants to try this drug. It's the next wonder drug apparently for all cancers in patients' mindset, of course, because of literature coming early on from the melanoma trials. But I'll just go over the rationale a little bit. And I drew this at the time when it was just exploding in melanoma world, but basically, tumor cells try to outsmart our cellular immunity by applying brakes on the CD8 T cells, and that's just brakes are called PD-1, PD-L1 interaction. It could also be through CTLA4 molecules. So pretty much the rationale for using immunotherapy, that's a broad term, but immune checkpoint inhibitors is removing those brakes so that the CD8 T cells or innate immunity of the host basically takes over. And now we have data in macrophages as well in lymphoma that you're basically reactivating innate immunity to kill the tumor cells. So because of the strong biological rationale, the immune checkpoint inhibitors were studied in several cancers, resulted in significant improvement in outcomes. It was all over the news the first time the trial results were reported. Improvement in progression-free survival, overall survival in deadly malignancies such as melanoma, now in non-small cell lung cancer, and kept on getting approved by the FDA for one indication and the other. Now urothelial cancers, bladder cancers, recently head and neck cancer data is very promising, and it may lead to approval in that as well. But also in hematological neoplasms, which lagged behind early on, but classical Hodgkin lymphoma is another one. So as a fellow in hematology oncology, I would say that half of my patients currently are on immune checkpoint inhibitor on study or off study for one or the other cancer, not just the hematological cancers, but also for solid tumors. But the problem with all of these therapies, the immune therapies, is they benefit a small subset of the patient. Much research has been going into looking at how to pick those patients who benefit the most, because there is cost issues, and also, of course, we don't want to give it to the patients who won't benefit from it. So a lot of work has been done globally to look at what are the biomarkers that will help predict response to therapy. Initially, early on, a lot of work was by looking at PD-L1 expression by immunohistochemistry. Now, the antibodies are different now, depending on what drug you're using. And also one of the challenges with PD-L1 is every study defined overexpression in a different manner. Then there was a lot of work done in mismatch repair deficiency, which showed that mismatch repair deficient tumors, regardless of the origin or what kind of tumor it is, you can benefit by checkpoint blockade. And later on, tumor mutational burden was added on to that. So that's what I'm going to talk about. But just wanted to talk a little bit about what work has been done in histiocytic neoplasms. So PD-L1 expression has been looked at. And so in one study, it showed that PD-L1 was overexpressed in most of ECD, LCH, and histiocytic sarcoma patients. These are the number of patients, 3 out of 4, 7 out of 8, and the one patient tested for HS was high. but the PD-L1 expression was marked as greater than or equal to 2%. Another study that was done, their cutoff was 5%. So naturally, the percentage of cases positive for PD-L1 expression were lower than before. And there have been other LCH studies in that as well from our group that have looked at PD-L1 expression, and it is variable depending on what antibody you use, what expression level you mark it as. So what is tumor mutational burden? It's basically the number of mutations per coding region. These are somatic mutations within a tumor genome. They are reported as mutations per megabase of the genome. We know now, especially in melanoma and non-small cell lung cancer, as well as mismatch repair deficient colorectal cancer, that it's a very strong linear positive correlation with a response to checkpoint inhibitors if you have a higher tumor mutational burden, or also if you have mismatch repair deficiency status, which is defined by looking at germline mutations in which mismatch repair genes. So this is one of the very informative papers which essentially looked at tumor mutational burdens as the number of median number of coding somatic mutations per megabase, and the objective response rate was on the y-axis. So I tried to plot this curve based on that. So all the ones in green are the ones that we know immune checkpoint inhibitors have shown good response rates, at least. And as far as mismatch repair deficient colorectal cancer and renal cancer, and I've dropped lines to show the median tumor mutational burden in these patients. And then in red, I don't know if you guys can see, but sarcoma, breast, pancreatic cancer, mismatch repair proficient, colorectal cancer, and several other cancers. They looked at 27 overall cancers, and the testing that was done, they used Foundation Medicine data to look for tumor mutational burden. The initial studies that were done was using whole exome sequencing, but it was more cumbersome and costly, but it was very well correlated in this study and others. So as you can see, as you drop below a certain number, below 10 or below 5, that's where the response rates keep getting lower. And then this was another study basically just reporting tumor mutational burden. The ones in red are the ones that had CR or a PR to immune checkpoint inhibitors, best responses. So these are melanoma and non-small cell lung cancer. These are essentially the poster childs for immunotherapy currently, or immune checkpoint inhibitors. So what we have learned is essentially a lack of response or less than 5 mutations per megabase tumor mutational burden, and the malignancies that are very responsive to checkpoint inhibitor therapy, like melanoma, mismatch repair deficient colorectal cancer, have a higher tumor mutational burden than that. So our objective here was to look at tumor mutational burden in histiocytic neoplasms that were seen at our institution. We also had some data on some patients on mRNA expression on PD-L1, PD-1 expression, but that was just an exploratory endpoint, and that's not a primary objective of this study. So we included ECD, Rosai-Dorfman disease, adult LCH, and histiocytic sarcoma patients. These were consented to an institutional protocol of all cancers using tissue genotyping by NGS and correlation with clinical outcomes. So the NGS method that was used was a Tempus assay, that name is XO, which utilizes 1,700 genes that are somatic and germline DNA that have been implicated in malignancies, and also RNA sequencing. The alterations that it identifies is indels, copy number alterations, gene rearrangements, and single nucleotide polymorphisms. So TMB was calculated and reported as somatic mutations in tumor tissue per million base pairs, or mutations per megabase. And RNA sequencing was also done for PD-L1 and PD-1 gene expression, and it was compared to matched tumor and normal reference sets. So it was reported as percentiles. Now I have to preface this by saying that this has not been validated, the RNA expression part. There are some studies on it, but most of the studies on immune checkpoint inhibitor and PD-1, PD-L1 expression are through immunohistochemistry. Also looked at DNA mismatch repair status by looking at the alterations in mismatch repair genes. If there was an alteration, if there was no alteration found in those genes, it was reported as microsatellite stable. So essentially this is the takeaway slide, or the main slide here, is across the board, other than histiocytic sarcoma, all these patients had a low tumor mutational burden. In fact, there was one patient with RDD who had very high tumor mutational burden, and it stood out. So we went back and looked at what tissue was sequenced, and turns out the patient had 2 cancers at the same time. So the uterine endometrial cancer was the one that was sequenced. So we went back and sequenced the RDD sample in that patient that was low. So even in ECD, the only one patient of histiocytic sarcoma we had a higher tumor mutational burden than rest of the patients clearly. So just looking at ECD cohort, these are the characteristics of the 3 patients that were in the study. There were a couple of patients who did not have enough DNA, and several others. That is one of the challenges with these studies, are not enough mRNA or DNA or test failure and so forth that can happen. But both the patients who had BRAF V600E status in the tumor had a higher PD-1 or PD-L1 expression in terms of the percentile. And one patient who we were able to do mismatch repair deficiency was microsatellite stable, so no alterations in mismatch repair genes, deficiency genes were found. And these are rest of the cohort of the histiocytosis, Rosai-Dorfman disease, LCH, and histiocytic sarcoma patients. We primarily had some data for PD-1, PD-L1 expression in Rosai-Dorfman disease, except 2 patients. Rest of them we had data on was very low PD-1, PD-L1 expression. And the mismatch repair status was whatever patients it was available for, it was all microsatellite stable. So no microsatellite, no mismatch repair deficiency through this criteria were seen. Now, of course, there are limitations to this study, small sample size due to the rarity of the condition. These were all patients that were seen in the last year. PD-L1 expression was not confirmed by IHC methods in these patients specifically, and half of the patients did not have RNA expression available because of the lack of tissue or test failure. So I would take these results with a little grain of salt. I would just focus on the TMB here. So in summary, at least ECD, RDD, and LCH from our data shows that they have low tumor mutational burden. From the TMB standpoint, this predicts a lack of response to immune checkpoint inhibitor therapy. Histiocytic sarcoma had a higher TMB, the one case we had at least than others, and there is a case report recently that was published looking, it was a case of nivolumab inducing a response in a patient with histiocytic sarcoma that progressed after systemic chemotherapy. BRAF V600E ECD, if those 2 patients had high PD-L1 expression and PD-1 expression on RNA sequencing. IDD, whatever patients we had, most of them had low PD-L1 expression. So other than the TMB standpoint, the other thing I looked at a little bit about the macrophage biology in these diseases. So there is some evidence that there is, and I'm not a biologist, I have to preface that, but there's some evidence that there is M1 polarization, M1 versus M2. M1 are pro-inflammatory macrophages, so there is M1 polarization in these disorders to begin with. And there is also evidence that immune checkpoint inhibitors also can induce M1 polarization. So at least from a theoretical standpoint, the rationale doesn't fit, at least from these two criteria. But of course, that doesn't mean we should throw it off the table. We have to look at other biomarkers as well as immunotherapy markers as they improve to keep an eye on this particular treatment. And as immunotherapies evolve as well, we now have macrophage-based immunotherapy that's coming in. So that's something to keep in mind as we look at therapeutics for ECD, LCH, and other histiocytosis as we are looking at other cancers alongside and larger cohorts, probably in a collaborative manner. But that's all I had. Please ask any questions if you have.
We're going to do 2 questions in the interest of time, so we can move forward with the rest.
So I wonder if we can engineer it from the other side, because on one hand we have the histiocyte, which has a low mutational burden and appears not to be immune reactive, but on the other side we do have the immune system. And I wonder if the immune system can be forced to recognize ECD histiocytes as a threat, because, eventually speaking, the perspective of a cure, as we see, is not going to arrive from biological therapy. We're talking about how are we going to handle long-term biological therapy in young patients. So I would love to know your opinion on it.
I know exactly, and that's what the point is. After the LOVE study results, it's like, we see these patients at the age of 45, 50, and they have to be committed to targeted therapy for the rest of their life, essentially, from what we know. So, that's one of my areas of interest. That's why I explored this. I have no concrete ideas right now as to how we can train our own immune systems, innate immunity, to fight its sort of immune effector cells, which macrophages are part of that. Maybe macrophage-based therapies may have some value to it, but I'm not sure right now from the immunity.
So just throwing it into the crowd, maybe we should think about focusing on a mass cytometry attitude toward research here, trying to define the overall proteome of these aberrant macrophages as opposed to the normal macrophages. I don't know, even maybe use monoclonal antibodies, bispecific monoclonal antibodies versus peptide MHC with the mutant BRAF, along other marker of a healthy macrophage.
That's a great thought. I don't know if anybody else has any experience with
But
this.
because you show here that you find high expression. Back in 2016, I found low expression. We used 2 different methods. So where the truth is, we need to find the truth.
Exactly. Yes, certainly.
Yeah, very nice work, but the drugs can be quite...
There are quite many side effects, like of the immune checkpoints. Like I wouldn't use like nivolumab for like a patient who is not like really severely affected by ECD, and so between targeted therapies and immune checkpoints, I mean, I think I would definitely treat by targeted therapy rather than immune checkpoints.
I agree. For ECD, we have biological rationale, but if you're talking about side effects, I treat both. I use BRAF MEK inhibitor for melanoma, and I have immunotherapy. The immunotherapy is overall breeze through. It's very low side effects. Quality of life, that's a whole different discussion about targeted therapy versus immunotherapy.
You mean for melanoma, right?
For other cancers,
oh, yeah, for
all
other
cancers
yeah.
overall, wherever lung cancer, targeted therapy of any sort has a lot of other side effects. So at least on that point, I could argue that just from a side effect standpoint, yes, the dreaded side effects of immunotherapy or immune checkpoint inhibitors are bad, but they are less than 5%, at least if you pool all the data together. And the rationale for using your immune system is you induce memory in it. So the rationale is now in melanoma, we are looking at discontinuation studies for, you are reaching the tail of the curve. So there's a lot of lessons to learn from melanoma, especially from BRAF story. As those patients we are stopping, I have a patient we stopped the checkpoint inhibitor, has been in remission overall. So the whole rationale is, can we do something different from a different angle, from a cellular standpoint, to induce remission? But currently in ECD, if you have a BRAF V600 mutant, that's the way to go. So again, it's just a search for a rationale, not necessarily to use nivolumab, not necessarily to use pembrolizumab, but actually going beyond it and seeing what immune mechanisms are there. And so that's not a, when I say immunotherapy, it's not just nivolumab and pembrolizumab. There's a lot of other things that are on the horizon and actually being looked at. Improved antibodies that have less immune side effects as well.